Okay, we'll start now.
Yes, sir.
Good evening. Welcome to this talk by Dr. Jeff Young, who's a kinesiologist. Right now, he is having his own clinic in New York. He did his kinesiology exercise science in Pennsylvania State University, USA, from 92 to 96. And then also he's a licensed American College of Sports Medicine specialist, also certified strength and conditioning specialist. And he's the founding chair of the Fitness and Medicine Working Group, American College of Lifestyle Medicine from 17 to 21, and also a continuing education provider for National Academy of Sports Medicine from 13 to present. And he's also a dual committee member for Greater New York's regional chapter for students and programming committees from 2018 to now present. He's also a medical fitness consultant for American Physical Therapy Association. He is a lecturer for Pennsylvania State University kinesiology program since 13. He's also a continuing education provider for the National Academy of Sports Medicine in 2013. So with vast experience, he'll be talking to us about the strength training and conditioning. So he's a specialist in that. We are very thankful to Dr. Jeff for accepting this invitation and will be speaking to us. And it's going to be interesting. And I'm sure people are there with questions. They'll be asking at the end of the program. And thank you once again, sir. We can start your session. Sam, you want to give any instruction, anything? Sam Karwa.
Yes.
And here, Sam. Dr. Jeff, just 1 minute. Before we start, Samuel Krubagaran will give tips to about the Zoom meeting.
Are you asking me or are you asking Sam?
No.
Yeah.
I'm asking Sam.
Yes.
Yeah, I was muted so far. We can keep our mics under mute and Jeff can take over, and then we can discuss after the talk.
Okay.
Right.
Yes.
All right. So first of all, thank you very much for both the introduction and for reaching out and having me perform this presentation. Is obviously very cool for me to be in New York City and be able to present, virtually to India. So this is only my second time ever presenting internationally. So it's very, very cool experience and I appreciate it. By the way, let me also just say that I have to do two things simultaneously here in the beginning. I have to begin my presentation, but at the same time, keep my eye on the waiting room and admit people as they're coming in. So please just bear with me here early on. But yes, Sam and Andrew reached out to me and asked for me to present on strength training, especially as it relates to rehabilitation and post-rehabilitation and dosing, such as with frequency, volume, intensity, etc. So that's what my presentation is going to be about. And I'll go with that said, I'll go ahead and get started. The first thing I wanted to do in my presentation before I get into program design principles is talk about just general foundational principles of both exercise and as they relate to program design. So I'm going to start with that as the foundation of this presentation, and then I will move into the actual program design variables. And what I did was, with these first several slides, I categorized the principles of exercise under different umbrellas. And the first umbrella is the need for variation. So, and by the way, you're more than welcome as I'm presenting to unmute yourself if you want and chime in with any questions that you have. I actually do best in a informal question and answer type of atmosphere. So if you have any questions or comments as I'm moving through these slides, please feel free to unmute yourself and grab my attention. So the first principle of exercise I wanted to cover, and I'm not covering every single one, I'm just covering principles that are important for this particular presentation, is called Sales General Adaptation Syndrome. And it basically states that the body goes through 3 stages when it's presented with a stress. And this can be any stress, but in here we're talking about exercise, and more specifically, we're talking about resistance training. So the stages that the body goes through when it's presented with the stress, the first stage is known as shock or alarm. So this bottom blue line represents the body's want and need for homeostasis. So the body is always trying to keep a balance, and it doesn't want its balance or homeostasis disrupted. But when it's presented with the stress, and in this case, exercise and resistance training, there's a disruption to the homeostasis, and it is a shock to the system. The body doesn't recognize the stress, and what happens is the performance is affected, and the performance will begin to decrease. And in resistance training, this is where you're typically going to feel your soreness, most of your soreness. This stage typically lasts for a minimum of 2 weeks, and it could be up to several months. It's dependent upon a lot of factors, but especially the individual's fitness level. So the more deconditioned they are, the longer they'll the longer they'll stay in this shock or alarm stage, and the longer they're going to feel their soreness, and their performance is going to decrease. But at some point within the 2 weeks to several months, the body is going to start recognizing the stress, and it's going to move to stage 2, where it is now resisting the stress and adapting to it. And this is the stage we want to be in. This is the stage where performance is now increasing. You're seeing their strength increase, maybe their conditioning. And as long as they aren't sabotaging things with a bad diet or other things like poor sleep habits or something like that, you're also going to be seeing their health improving as well. So this is stage 2 of the 3 stages, and this is the stage your body wants to be in. But at some point, your body is going to adapt to the stress. It can't keep adapting forever. And that will then lead to stage 3, which is known as plateau, staleness, or exhaustion. And the whole point of this principle is that there is a need for variation. We can't always keep hitting the body with the same stress. And in the case of rehabilitation, it means that we don't always want to be performing 3 sets of 10 to 12 repetitions, of the same general exercises over and over again. And there's actually going to be some more principles related to this as well, which I'm going to get to in a second. But let me move on to the next principle, which is called the principle of variation. And it refers to planned variation, where a lot of people think that this refers to the need to change up exercises all the time, but it's actually referring more to varying frequency, volume, sets per session and per week, the repetition ranges, corresponding rest periods, the order of exercise, and movement tempo. So the principle of variation is obviously referring to the need to include variation in program design, but more specifically, these variables. The next one under the umbrella of a need for variation is the principle of individualization. And this is referring to a need to determine an individual's unique initial capacity. And more specifically, what that means is the more deconditioned a person is, the lower their initial capacity. And therefore, like I said previously, the longer they're probably going to stay in the stage 1 of the general adaptation theory, the shock or alarm stage, and their rate of progression may need to be slower. Someone who has a higher initial capacity, such as an athlete who's healthier, stronger, and more conditioned, is probably going to respond more quickly to training, and their rate of progression may be able to be faster, but it's very case dependent. This principle also refers to the need to take into consideration as I just mentioned, their level of fitness and health, their exercise history, their level of motivation, lifestyle, and nutritional habits. And then there's a kind of little known principle related to exercise called the law of diminishing returns. And it's very much related to sales general adaptation theory or syndrome, which basically states that monotonous training leads to stagnation. The central nervous system will no longer be challenged to adapt. So this gets back again to that it's inefficient and ineffective over the long term to always be performing 2 or 3 sets of 10 or 12 repetitions, for example, and or the same amount of exercise. I'm sorry, the same types of exercise. We need to vary things. The next umbrella is the need for progression. There's 2 principles that I'll cite here, which you've probably heard of. The principle of progression, which refers to a need to modify exercise program over time by progressing in frequency, volume, intensity, and or from a simple to a complex exercise. And I'll be talking about this in more detail once I get into later on in this presentation when I'm talking more specifically about program design principles. I just wanted to start with a general overview of exercise principles. And the next one is the principle of overload, which is very closely related to the principle of progression. A lot of times it's referred to as progressive overload. And this is defined as training should slightly exceed what the individual is accustomed to or the previous workout. So we want to continue to progress in basically the intensity as well. And this is accomplished by increasing sets per muscle group, varying set repetitions per set and the corresponding load, and or decreasing rest between sets. All right, continuing with foundational principles of exercise, there's a principle known as Henneman's size principle of strength and Henneman's size principle of hypertrophy. And the next few slides are going to be on the size principle of strength, which I'm going to spend a little bit of time on. And then I'm just going to give a really quick overview of the size principle of hypertrophy and how it relates. So strength training as a system revolves around Henneman's size principle. And more specifically, what this principle states is that motor units, and therefore the corresponding muscle fibers, or we can just say muscle tissue, are recruited in order of size from small to large, and therefore from type 1 endurance fibers to type 2 strength fibers. The task or the load and the proximity to muscle failure are going to be what the 2 main variables that determine the number of motor units and therefore the amount of muscle tissue that is recruited. It's ridiculously important to understand that only recruited motor units are trained. So just to give a quick example, if I were to, I'm going to raise my arm here, if I were to flex my bicep and let's say I was holding a 5-pound dumbbell, for example, and if I were to curl that 5-pound dumbbell, it's extremely lightweight for me. To your naked eye, it may look like my whole bicep is contracting, but under a microscope, only the number of motor units that are needed to perform that task are actually being recruited and activated, and the rest are not producing force. They're literally at rest, and they are just going along for the ride. So it's really extremely important to understand the magnitude of this principle. It's one of the most important principles of exercise in general and resistance training more specifically. We need the load to be such that, not necessarily initially, especially when the person's obviously in rehab and there's swelling and there's tissue damage that needs to heal. Obviously, in a situation like that, you don't want the loads to be too high, and you don't want to take the person too close to muscle failure. But it's really important to understand this principle, because as tissue heals and the person is now able to progress, it's really important to understand that load and the intensity needs to be such that it is at or near muscle failure. And I will be talking about this in more detail later in this presentation. So to be trained, fatigue must occur. And if fatigue is occurring, it's going to manifest itself in a decrease in power, which visually means the velocity of movement is going to slow. So if the velocity of movement hasn't slowed, then neuromuscular fatigue has not truly occurred, and you're only going to recruit a fraction of the muscle of the motor units, and therefore the muscle tissue. And even though you probably can't see this chart, this is from a study or a narrative review called Muscle Activity and Inactivity Periods During Normal Daily Life. And basically what this review showed and what this chart is showing is that in normal activities of daily living, only approximately 4 to 20% of muscle tissue is being activated, which means 80 to 96% of muscle tissue is not being activated in normal activities of daily living. And this is a huge reason why in the aging process, strength fibers are not being used. They're the first to go, and it leads to deconditioning and eventually, for a subset of the population, to frailty syndrome and all the associated problems with this loss in strength and function. So it's just another reason why it's so important to understand this this principle, and to understand that unless you are resistance training with adequate intensity over the course of time, you are not using a lot of your muscle tissue, and you're going to, if you don't use it, you're going to lose it. This next slide is just to give a little bit more visual clarity to what I just said, and to show that on a continuum, if you can perform any movement whatsoever, where you can perform more than, say, 12 to 15 repetitions, for the most part, unless that activity is such that you are taking yourself to muscle failure or very close to it, you are only recruiting endurance muscle fibers and no strength motor units or the corresponding muscle fibers. It's not really until you start loading up so that you can only perform about 6 to 12 repetitions, where now you are starting to train, you're starting to recruit and train strength fibers as well. And once again, this is very dependent on taking yourself to at or near muscle failure. And then in the 1 to 5 repetition range with very heavy loads, now you're recruiting most or all of the motor unit pool. Excuse me while I admit some more people. And so the last slide on this Henneman size principle of strength is just another visual to show how it relates to the repetition continuum. So typically, I can't speak for what's going on in India, but here in the United States, it's very common for rehab to revolve around 10 to 12 repetitions per exercise, but because the person is in rehab and they're in pain, or there's swelling or inflammation, and or tissue is healing, the loads are not such that the person is being taken to at or near muscle failure. So in other words, sets are being terminated where the person technically, if they had to, could have performed 15 or 20 or even more repetitions. It's just that the sets are being terminated at 10 to 12. So even though on this continuum that it may seem like 10 to 12 is moderate weight, it is only moderate weight when you are loading up so that the load is such that you're taking yourself to at or near muscle failure. Otherwise, basically, you're lifting light and very light weights. And while this is beneficial for a time, in the long term, it is not, because you're going to have very little effect on your strength. You may have effect on your local muscle endurance, or what's known as strength endurance, if the sets are being taken to at or near muscle failure, but you're going to have very little effect on your strength, and only a fraction of your muscle tissue is being recruited. But once you get down in here in the 4 to 6, 6 to 8, 8 to 10 repetition range. Now, as long as the sets are being taken to at or near muscle failure, there's going to be a lot more tissue recruited, and the effect on overall strength is going to be much greater. And then just very briefly, I'm going to mention the difference between the size principle of strength and the size principle of hypertrophy. Because as you may be aware, recent research is showing that you can increase lean muscle tissue or muscle hypertrophy with light loads, even up in the 30 repetitions per set range, and maybe as high as 40 repetitions per set. So I'm just going to give you my own personal view, and you can do with this information as you please. But my personal view is that while if it's post-surgery, or the person is extremely deconditioned, maybe bedridden as an example, then yes, it is important to, and these would be outlier situations where it is beneficial to load someone up with very light weight and repetitions where it might be 15 to 20, 20 to 25, 25 to 30, in order to at least get some muscle tissue increasing. But the problem is that the higher the repetition range, and therefore the lighter the load, the more important it becomes to take yourself to at or near muscle failure in order to see these adaptations, and therefore the discomfort that goes along with it and that burning sensation. So while it's true that you can increase lean muscle tissue with light loads and higher repetition ranges, you're going to have very little effect on your strength because the load is so light that there's going to be very little neural drive. And so you're not going to have much of an increase in strength unless the person is really deconditioned, but you're never going to get out of a beginner range of strength. And so it's always important to just keep in mind that that should just be a short-term intervention, and that ultimately you want to train across the 6 to 12, 4 to 12, 6 to 15 repetition range, somewhere in that range. So now I'm going to switch gears before I get into the program design principles and dosing, and just briefly mention that while there are many things there are many mechanisms that are associated with and increase the risk of injury. Excuse me while I invite someone else. So there are many mechanisms that are associated with and increase the risk for injury, but there's only one cause of injury. And the cause of injury is that in the moment of time the injury occurred, the injured tissue or tissues lacked the capacity and therefore couldn't tolerate the load, stress, or force that was placed upon it, more specifically shear, compressive, or torque forces. So the tolerance wasn't there, and that's the reason why the injury occurred, which underscores the need to increase tissue tolerance, and therefore to place the person on a strength and conditioning program above and beyond what occurs a lot of times in physiotherapy or rehabilitation, which I'm just speaking for the United States, because I don't want to point fingers at physiotherapists as though it's the fault of physiotherapists so much that it's the fault of insurance dictating the time limitations that the patient has, and many other factors. But whenever possible, we want to try to get individuals strengthening above and beyond what goes on in short-term rehab and turn it into a lifelong activity. Okay, so this I think is my last slide before, actually I have this slide and one more before I really get into the program design principles. And the reason why I put this slide in is just to briefly explain that the design of programs and more specifically optimizing program design is so dependent on what I like to refer to as a motivation and means continuum. So by motivation, I more specifically mean the value and or enjoyment the person gets out of the activity. And by means, I'm referring more specifically to their access to finances and access to equipment. So what I mean by this is that on one end of the continuum, you have an individual who may lack access to a well-equipped facility and or professional guidance, and or they have low motivation for whatever reason. On this end of the continuum, like I can talk to you about how to optimize frequency and volume and intensity all I want, which I'm going to, but if the person lacks the access to a well-equipped facility, professional guidance, or they just have low motivation, then obviously you're only going to be able to progress that person so much. On the other end of the continuum, where an individual does have access to a well-equipped facility and or professional guidance and or they're highly motivated, this type of person is going to be much easier to progress, and it's going to be easier to optimize their program design. So even though I think this is common sense, please just keep it in mind. We obviously have to take everything case by case and understand that it's going to be more difficult to optimize the design of an exercise program if the person is really lacking access to heavier loads, a lot of variety of free weight and machine equipment. Maybe they have financial issues and they can't afford professional guidance for any real length of time, and or they have low motivation. So like I said, it affects the optimization of program design. But having said that, as I'm sure you're aware, it can be a dynamic situation. So in other words, just because you may start on the low end doesn't mean that you're going to stay on the low end. We as professionals, whether it's physiotherapy, physicians, physiotherapists, or someone like myself, a kinesiologist or an exercise specialist, can absolutely affect their motivation and try and move them forward in the continuum. And maybe over the course of time, their access to equipment might change as well. Maybe their financial situation could change, or we might be able to talk them into investing into some light dumbbells, for example, or some heavier ankle weights or something like that. And I also just wanted to quickly state that it's important for physiotherapists to understand their role in helping to change behavior, and that behavior change begins with rehab. So, for instance, you might have someone who was sedentary and had no desire to exercise whatsoever, but now they're being forced to exercise because of an injury. And you can use this injury and the pain they're experiencing as a starting point, as a jumping off point to begin to change their behavior and get them to understand the need to, you can educate them on the need to increase tissue strength and tolerance. And that if rehab is short term, you're only going to be able to get that process started, and that it's really important for them to continue on with their plan of care after they are discharged from rehabilitation, if they don't want to get re-injured and be back in physiotherapy again. So I just want to point that out as well. Okay, so now this is my last slide before I get into the dosing and program design. This is just very generally speaking, so this isn't going to cover every single situation, but generally speaking, there are 4 stages to musculoskeletal rehabilitation. And by the way, these stages are not completely separate from each other, as you all know. I'm preaching to the choir here. They absolutely can overlap. But generally speaking, stage 1 is where you want to reduce or negate pain and swelling and inflammation. Most likely it's the reason why they're in rehab to begin with. Stage 2, which can overlap with stage 1, is where we want to restore range of motion to at or near normal. The joint has shut down because it's injured, because of the swelling, because of the pain. So we want to focus on mobility very early on in the rehab process. Stage 3, which can also overlap with stage 1 and 2. It doesn't necessarily have to be a situation where you leave stage 1 and 2 before you can go stage 3. And that's where we're going to start to restore or improve motor control and begin to strengthen the tissue. And a lot of times in rehab, as you know, this is going to revolve around a lot of lighter therapeutic exercises. Many of them tend to be single joint exercises such as, or like balance exercises like standing on one leg, or TheraBand exercises where you're just working on one joint at a time. And once again, I can't speak to what's going on in India, but here in the United States, because of insurance limitations, unless the person is in rehab long term because of maybe a ACL rupture, or post like a joint replacement surgery or something like that, stage 4 either doesn't occur in rehab here in the United States, or it's short term. When the truth is, stage 4 should be a lifelong stage. It should be a stage that the patient moves to and they remain there for the rest of their life in a perfect world situation. So this is the stage where we continue to restore and improve motor control, but we involve more of the kinetic chain, such as sit to stand or squats, deadlifts, multi-directional lunges, chest press exercise, rowing exercises, overhead press if it's appropriate for the person, etc. We want to start to increase the loads and the conditions of fatigue. We want to do this in multiple planes of motion. And we also, in a perfect world, want to increase their variety, their exercise selection, the amount of sets they're performing in a session and within the scope of a week, a wider spectrum of repetition ranges, which I'm going to get to more in a second, the progression of loads, and total body strengthening rather than just the area that was injured, which here in the United States is dictated by insurance, that the person is not being put on a total body program because of insurance, and they're only able to rehab the area or areas that were injured, rather than total body. So it's just so important whenever possible to try to move the patient through the continuum and get them to understand that, yes, we might be putting you on a home exercise program if they don't have access to a gym or a health club, but it's still important to try to get them to understand the need to move to stage 4, educate them on what stage 4 is, and that stage 4 really should be a long-term, preferably lifelong stage. So with all that said, now we're going to get into program design guidelines and dosing. And let me just start by saying that these first few slides are kind of, even though I'm not a physiotherapist and I do the post-rehab and medical fitness and general fitness end of the continuum, there's obviously a lot of overlap between what we do and between program design. So I'm going to be talking about these next couple of slides kind of a little bit more from my perspective, but I think you'll be able to see that there's a huge overlap in it. And what I'm trying to do is just paint a bigger picture for everybody, a picture that goes above and beyond just rehabilitation. So there are 2 categories to program design. The initial program design, which we can call the familiarization phase, or some people will call it the adaptation phase. And then the next phase is, I also want to say that this phase is, as you're getting ready to see in my next slide, is very closely related to what occurs in physiotherapy for the general population. And then stage 2, or the second category, is progression. So once they have finished the initial program design, how are we going to progress them? So the American College of Sports Medicine, which is one of the governing bodies in exercise science, has a mantra, and which basically says start low and go slow, or progress slow. More specifically, it just means start conservatively, and within that person's initial, this is where you have to determine the individual's initial capacity and stay within it and stay within their comfort zone to make sure that that the volume and the intensity isn't too high, that we worsen the injury or cause an injury or some sort of related flare-up. And from a program design standpoint, and especially from a repetition range standpoint, this is where, like, what I do with my referrals, my clients, I typically will start them at 10 repetitions per set, which is very closely related with physiotherapy. And the purpose of this initial stage is very closely related to physiotherapy. We are trying to determine available pain-free range of motion, teach them the names of exercises, teach them proper form, or what you all call motor control, neuromuscular control, neuromuscular re-education. The flow, in my case, it'd be the flow of a session. And we're using rate of perceived exertion or rate of perceived effort scales to determine the initial loads and to determine their rates of progression. And during the course of this phase, which can last anywhere from maybe just a couple weeks to several months, we are trying to increase their effort that they're putting into a set, or in other words, how close they're going to muscle failure. And we're also using verbal, visual, and tactile cueing to help establish mind-muscle connections. And the end of the stage is typically determined by the patient or the client is now showing proficiency in movement. So in other words, the cueing is becoming less and less, and the movement itself is starting to become very familiar with them, so that we don't have to cue them so much, and they're establishing proper form and establishing proper movement patterns. And the intensity has reached a level where the rate of perceived exertion is now approximately a 7 on a 1 to 10 scale, which I'm going to get into more detail here in a second, and what that means. The velocity of movement is beginning to slow. And what that means is it's now a true working set. So in other words, when they're showing proper form and the sets are true working sets, it is time to move them out of the initial stage. And it's time to now progress them. And so what that means, and it can actually mean a lot of things, but from an exercise science standpoint, the most logical and simple way to progress them is to move them from the initial 10 to 12 repetitions per set where they were at in the initial stage, and actually to increase the repetitions to 12 to 15, where then we're actually going to lighten the load. But sets are now being taken to near muscle failure, not necessarily to at muscle failure, but at least to near muscle failure. And we keep them at 12 to 15 repetitions per set for every exercise that they're performing, with the exception of core exercises like abdominal exercises. But setting abdominal and core exercises to the side, every exercise they perform should be in the 12 to 15 repetition range for approximately a 3 to 4 week phase. And the purpose of this phase, the primary purpose, is to increase their strength at 12 to 15 repetitions per set, so that at the end of the phase, in other words, let's say it's 4 weeks, so that at week 4, they're a little stronger at 12 to 15 repetitions per set in every exercise as compared with week 1. And what that does is it prepares both their mind and their body to reduce the repetitions back to 10 to 12 repetitions per set. It's just a small reduction in repetitions. We increase the load accordingly because they're now performing 2 less repetitions per set. We keep them there for a 3 to 4 week phase. And once again, the primary purpose of the phase is to increase strength, so that at the end of the phase, they're a little stronger in every exercise than they were in week 1. And this then prepares the mind and the body for when we reduce them to 8 to 10 repetitions per set. Once again, it's a 3 to 4 week phase. Once again, the primary purpose is to increase strength, so that at the end of the phase, they're a little stronger. And what I mean by that is, even if it's only a pound, an increase in a pound or 2 pounds or 5 pounds, as long as they're not using the same loads every single week in this phase, and that we're slightly increasing their strength, we just want to progress them at whatever rate we can progress them. And then at that point, it depends so much on their motivation. It kind of just becomes an executive decision between the therapist, between the coach and the patient, as to whether or not we move them to 6 to 8 repetitions per set. In a perfect world, we want to move them to 6 to 8 repetitions because of that Henneman size principle and the need to recruit more motor units and therefore more muscle tissue. So we really want to try to get most individuals down into the 6 to 8 repetition range. I've been doing this for 26 years. Once again, I'm in post-rehab, and I have found that most patient referrals are eventually able to go down to 6 to 8 repetitions, and many of them actually to 4 to 6 repetitions. It might not be right away. I might have to cycle through these phases of 2 or 3 times before their fitness level and their strength and conditioning reaches a point where I can bring them down to 6 to 8 or to 4 to 6. but it's always in the front of my mind that I don't want to always keep them at 8 to 10, 10 to 12, and 12 to 15 repetitions, because that means that they're always training with light and at the most moderate loads. And I'm limiting how much muscle tissue I am training, and I'm limiting how strong I'm getting them. And then the risk of re-injury is not lowering to the point that I want it to lower. So I'm always keeping in mind that at some point in the program, even if it's not for 6 months or a year, I want to try to get that person at the very least down to 6 to 8 repetitions per set. So other things going on in this whole, these individual categories are known as phases, and the whole thing is known as a cycle. So other things that are going on within this cycle is that you're continuing to increase their proximity to muscle failure. I pretty much never take clients to muscle failure because there's just really no need, but I am taking them to somewhere near it. We start to vary session intensity. We don't always want sessions to be light, but we also don't always want them to be hard, hard, hard. So within the scope of a week, I'll have some lighter sessions and some harder sessions. We start to increase variety. We try to increase sets per muscle group. So that's not always just 2 sets or 3 sets per muscle group in a scope of a session. We want to sometimes increase it to 4 or 5 if we can. And by default, just by increasing strength within each repetition range, you're also going to increase local muscle endurance in the higher repetition ranges, and therefore their overall conditioning and ability to tolerate fatigue. Obviously, we're going to increase their strength. We're going to increase lean muscle tissue. We're going to improve joint stability. So just by increasing strength in these various repetition ranges, we're going to do a lot more things that's going to benefit their health and their neuromusculoskeletal system. So this is known as systematic variety in a linear fashion, and it's just a really common sense way to design a program that I learned from the premier strength and conditioning researcher in the world when I was at Penn State University, and I've been applying this for 26 years. Okay, so now we're winding this up with the dosing and just talking about it a little bit more specifically. When it comes to frequency, even though the governing body guidelines say that we should strengthen our muscle groups 2 to 3 times per week, and then from an aerobic exercise standpoint, preferably 30 or more minutes per day, 5 days a week. The truth is, time and desire is really what's going to dictate what the frequency is. And from a resistance training standpoint, if the person only has the time or desire to strengthen 2 to 3 days per week, then that's where we want to place them ultimately on a total body program. But if they have the time or desire to train 4 or more days per week, we don't want to train total body every time. Now we want to put them on a split routine format where, for example, they're training their lower body twice per week and their upper body twice per week, or they're doing push exercises twice per week and pull exercises twice per week. So that's the difference between total body and split routines, and frequency is the primary thing that dictates that. From a volume standpoint, and once again, just talking about resistance training, this typically refers to what's called a set volume, or in other words, how many sets per muscle group the individual is performing within the scope of a session and within the scope of a week. So the governing body guidelines tell you to start with approximately 2 to 3 sets per muscle group per session. And that's also typically what's going on in rehabilitation. But it's extremely for you, even as physiotherapists, to understand and to educate your patients, in my opinion, that to optimize their strength and lean muscle tissue, they want to progress eventually to the point where there's a minimum of 10 sets per large muscle group. So in other words, your legs, your back, and your chest within the scope of a week. So if you do the math, that means that, for example, if the person is doing 3 total body sessions per week and they're doing 3 sets for their legs, back, and chest in each session, now they've hit 9 sets per large muscle group per week. And at least they're in that vicinity of the low end of this range. So please, this is not something I made up. This is a 2018 review of set volume to optimize set strength and hypertrophy, showed that the beginning of optimization starts at about 10 sets per large muscle group per week. So what that means is that if the person is only training twice per week and they're only doing 2 sets per major muscle group, that's only 4 sets in the scope of a week. We are never going to get them out of a beginner range of strength unless there's, extremely genetically gifted. So please just keep that in mind. That's just another reason why, the home exercise programs tend to underdose patients. They tend to just be low variety, low intensity, and low volume. And what typically happens that you're probably experiencing or are aware of is that the person ends up, they remain at risk for re-injury or for a new injury. And next thing you know, they're just staying through this negative cycle of they feel better for a while, and then next thing you know, they're getting re-injured or their joint pain's coming back, and they're back seeing to the physician. They're back in physical therapy, and they go through this negative cycle of never getting out of physiotherapy. They just stay out for a short period of time. And so much of it has to do with underdosing the volume. So please know this and educate your patients on the importance of progressing their sets per muscle group within a session, so that within the scope of a week, they at least get up to about 10 sessions per large muscle group per week. When it comes to the subject of intensity, there's 2 categories. There's objective intensity and subjective. Objective just means that we're taking the person's feelings and emotions and their rate of perceived effort. So in other words, their perceived effort out of the equation as though it doesn't exist. And we're only looking at the loads they're lifting. So on a continuum, if the load they're lifting is such that is so heavy that they can only lift it 1 to 4 times, then objectively that's known as very heavy weight. On the other end of the continuum, if they can lift a load 15 to 20 times before they reach at or near muscle failure, even though subjectively that's going to seem kind of hard for them because of the metabolic fatigue that accumulates and the burning sensation, and they're going to think to themselves, this just doesn't feel light to me. But the truth is, if you can lift a load 15 to 20 times, that is known as very lightweight. And then there's everything in between. So 1 to 4 is very heavy, 4 to 8 is heavy weight or heavy loads, 8 to 12 is considered moderate loads, 12 to 15 is light, and 15 to 20 is very light. And I also want to point out that the American College of Sports Medicine and the National Strength and Conditioning Association, which are the 2 governing bodies in exercise science, define general fitness from a strengthening standpoint as the 6 to 15 repetition range. So basically what they're saying is that most people should train across that whole spectrum of ranges of repetitions, that is. That way they're lifting sometimes with light loads, sometimes with moderate loads, and occasionally with heavy loads. And that goes back to that linear periodization that I explained to you. And this, a nice linear way to accomplish this is to start them at 12 to 15, 3 to 4 week phase, move them to 10 to 12, 8 to 10, and eventually 6 to 8. It's just a nice logical way to stay within the governing body guidelines of general fitness. Rest and recuperation, I'm not really going to talk about this for any length of time. The gist of it is that unless the goal is local muscle endurance and wanting to adapt to fatigue, in those cases, you do want to keep your rest between sets, in the 45 to 90 second range. Probably in rehabilitation, you don't really need to rest for very long between sets either. It could be 60, 1 to 2 minutes. Just because in rehab, the loads are typically light, you are not taking the individual to near muscle failure, and they can recover faster in between sets. But once they're discharged from physical therapy or physiotherapy, and they can start moving closer to muscle failure, it takes longer for the central nervous system to recuperate, and therefore the rest periods between sets need to be longer. So generally speaking, in the lower repetition ranges, like from 1 to 10 repetitions per set, you actually want to rest a minimum of about 2 or 3 minutes in like the 8 to 12 repetition range, and 3 to 5 minutes between sets in the 1 to 6 or 1 to 8 repetition range. And this is where why am I losing my train of thought? This is where supersetting and circuit training to increase the time efficiency of the session becomes really important, so that you aren't performing an exercise and then just waiting there for 3 or 4 or 5 minutes. You can perform, for instance, a chest exercise and then go do your back while your chest is technically resting a little bit, and then come back and perform your chest. Or what I do with my patients or clients is I typically go from a lower body to upper body. So I'll have them perform a leg exercise and then a back or rowing exercise, so that their legs are resting while we're doing their back. And by the time we get back to their performing a leg exercise, at least 2 to 3 minutes has gone by. From a subjective intensity standpoint, and these are now my last few slides, this actually is probably one of the most important variables in all of program design. And the reason why is because you can design the crappiest program for somebody, but if they're putting a lot of effort into each set, they're going to get results. Even on a bad program, they're going to get results for quite some time. Actually, it could be months or maybe even years, because the effort someone puts into a set is one of the most important variables in program design. And since most sets and really shouldn't be taking to muscle failure, that means that most sets are submax in nature, and therefore it is really important to understand subjective intensity. So give me a second here while I'm actually going to increase the size of this chart so that you can see it better. And now I'll go back. Okay. Even though this chart seems a little complex, the overall concept, I think, and you'll have to judge for yourselves, but I think the concept itself is very simple. There are 4 concepts that we need to merge, and they're all extremely closely related. One is RPE scales, and in this case, it's a 1 to 10 RPE scale. Another concept is repetitions in reserve, or in other words, when you terminate a set, how many repetitions could you have actually completed before you took yourself to muscle failure? Another is known as your face of strain, or in other words, the look of strain on your face as you perform a set. And then the last one, which is the most important variable, is the velocity of movement. So I could start either at the high end or the low end to explain these concepts, but I'm going to start at the low end. If the weight is so light that by the end of the set, and let's just say, for example, it's 10 repetitions in a set, and let's say I'm your patient and you give me a 1 pound dumbbell and tell me to perform a chest press with it or something like that. And then you ask me after I've completed the set, how did that 10th repetition feel? Not the 9 that preceded it. How did the 10th repetition feel? I'm probably going to answer you that it felt less than a 1. It probably felt like a 0.1 on a scale of 1 to 10. There was very little effort. I felt no fatigue. There was no look of strain on my face because I didn't need to strain. And the velocity of movement of every repetition looked the same. But if you start to take that same exercise and the same repetitions, and you start to increase the load, so now maybe you hand me a 30 pound dumbbell or a 40 pound dumbbell. And after the set is completed, you ask me, how did that last repetition feel? Not the ones that preceded, just the last one. First of all, the good thing about that is it's going to force me to start to have to develop a mind muscle connection, because I'm going to have to think about it and give you some sort of answer. And for me personally, that load I'd probably answer you about a 3 or a 4 on a scale of 1 to 10. It's still significantly far from muscle failure for me. I felt very little fatigue. There was no look of strain on my face, and the velocity movement didn't slow. But as hopefully you're starting to see, as we increase the load, at some point, you're going to start to see a look of strain on the person's face. And that's because fatigue is now starting to enter the equation. And you're going to start seeing the velocity of movement begin to slow, despite the intent of lifting the weight with velocity. And I have a video in the next slide, which is my last slide on this, to show you more specifically what I mean. But the point is that a set falls into one of two categories. It was either a warm-up set or a true working set. And the way we differentiate between a warm-up and a working set is that the velocity of movement began to slow. So if there's no slowing of the velocity of movement, it doesn't matter what the person thinks or, you know, what you might think of the set. It was not a true working set. We have to see velocity of movement slow. That's when neuromuscular fatigue is truly setting in, power is decreasing, and it is a true working set. And once again, in rehab, especially early on in rehab, we don't want to load a person up so much that this happens. We want to keep them in their comfort zone and keep the repetitions to, the rate of perceived exertion at approximately a 4 or a 5 on a scale of 1 to 10 to make sure that we're not flaring them up and giving tissue chance to heal, and et cetera, et cetera. But at some point, we need to start increasing the loads and increasing their proximity to muscle failure so that it's a true working set. Once it's a true working set, you don't necessarily need to go to a 10 where the movement came to a stop and the look of strain on their face was maximal. We don't need to do that ever, actually, in order to get the benefits of strength training. But we do need to take them somewhere near muscle failure. So 7, 8, or a 9. So hopefully that I explained it well and you understand, but I'm going to end with, hold on a second. I increased the size of the chart. And if I hadn't done that, this would be showing that the most important variable is the velocity of movement. But now I'm going to end with this video of me that I created many months ago. And it's just, I'm not going to show the whole video. It's like 5 minutes in length. I'm only going to show like the first couple minutes. But it's basically so you can have a visual of what I mean by the velocity of movement slowing. And I have a voiceover, so I'm going to be quiet and I'm going to let the video do the talking. But I'm going to show some chest exercises that I performed at different repetition ranges, and I'll show probably some back exercises, and then I'll stop the video. Flat dumbbell press, 12 repetitions. It's a light load objectively, which means I started off at a RPE of about a 4. Notice that every repetition, speed, velocity movement is pretty much the same. And soon where you'll start to see the velocity movement slow. So right there, slow just a little bit. And then you can definitely tell it slows a little bit more. I barely get this one, but I complete it. So it's a repetition maximum. And then I try one more time, can't get it. And that is the definition of muscle failure. So before I go on to the next one, hopefully you can hear what it's saying. And if for some reason you can't, please just understand that I want you to look at the velocity of movement of each repetition. And you're going to notice that early on, and that last repetition was 12 reps. This one is at 10. Then I do one at, I think, 7 and one at 4 or something like that. But you're going to notice that the heavier the load, the lower the velocity of movement begins with. But with lighter loads, you'll see that the first 5, 6, 7, 8 repetitions, actually the speed of the movement looks pretty similar until I start getting towards the end of the set, and then you're going to start seeing it slow. And if the velocity movement didn't slow, it was never a true working set. We needed to slow. And this, even though I'm showing chest and back exercises, this applies to everything. This applies to a sideline clam with a TheraBand. This applies to, you know, a chest fly or a leg press. It doesn't matter what the exercise is. We need to see the velocity of movements slow for it to be a true working set. Same exercise, but 10 repetitions per set. It's again, the RPE starts off at about a 4 or 5, so a little bit heavier load, but the speed of each repetition or velocity of movement is about the same for each rep until I get to about my 7th rep, and then it goes up a little bit slower. At this point now, each repetition or each successive one is going to get a little bit slower than the previous one. On this one, I barely get it, but I complete the repetition, so it is a repetition maximum. I'll intuitively not try another one because I'd fail. Now we're loading up so where I can only get 7 repetitions in the set. RPE starts heavier, like about a 5 right from the beginning, which is the reason why we get to a 7, 8, and 9 RPF, rate of perceived fatigue, a little bit quicker. And complete that one, so it's a repetition maximum. I try one more, muscle failure. And then finally, loading up so that right from the start, it feels like about a 7. I can only do 4 repetitions from the beginning as well. Before you know it, I'm already at a 10, but I complete the rep. So it's a repetition maximum. I'll show just a couple back exercises and then I'll stop. Repetitions again. Once again, look at my elbows and notice that I'm completing the rep a little bit behind my torso, and the speed or velocity of movement is about the same. Once I get up to about the 9th repetition, you'll start to see I struggle a little bit to get my elbow behind my body. The movement starts to slow. This is now when I'm in that true working set range. Barely get that one. Try one more. I can't get it. I'll show one more. Just for a different exercise. For 10s, we went with the single arm cable row. Watch again my elbow. It's going behind my body on each repetition, just a hair behind. The speed of every repetition looks about the same, but now it's starting to slow down, especially towards the end of the movement. There we get to a 10, rate of perceived fatigue. There I couldn't complete the movement. Okay, so I'm going to stop this. And so to kind of wrap this up, first of all, I apologize for spending so much time on that, but it's just such an important concept because there's so much underdosing going on in rehab and in the fitness world. And it's just so important to understand that this velocity of movement concept. The other thing I want to say, because I'm either finished my presentation and we can open it for questions, or, and this is totally up to Andrew and Sam, I am currently, as Sam knows, am dealing with a significant shoulder injury. And I could talk about that if you want me to for just like 5 minutes or so and then end the presentation, or because of time, since we're already at, we started 1 hour ago, since we're already at an hour, if you want to stop and open it up to questions, that's totally fine with me. Or if you want me to include, once again, I could probably do it in about 5 minutes. What's going on with my shoulder?
Yeah, I think you can have it. Yes, sir, you can have it the shoulder on, sir.
Yeah.
After we can have the questions.
Sure, that's fine. I'm actually curious if everything I said was, was understandable and did it make sense?
Jeff, I think we lost your slides. Are you displaying anything currently?
Hold on, let me turn my volume up. I wasn't able to hear you well. Go ahead, say it again.
We lost your slides on the screen. Are you still trying to show us your PowerPoint, or?
No, I thought that Andrew, I thought Andrew said that we should open it for questions, but if you want me to go through the case study of my shoulder very quickly, I can do that.
Okay. Yeah, we can do a quick
case study, sir,
discussion on your shoulder, because it would be interesting with your complete rupture of the biceps and a Popeye sign. Opting for a conservative management. I think we can hear you on that.
Okay, so you want me to do my case study?
Yes, sir. Yes, sir.
Okay.
Yes, sir.
Okay. I'll try to make this quick. All right. So, just to give you some background, and I don't want to go into too much detail unless you have questions afterwards, but somewhere around 7 or 8 months ago, I was creating an educational video, and I ended up having to take myself to muscle failure on a lot of sets. Like over the course of a 2-day period, I took myself to muscle failure on like 15 different exercises. And I almost never take myself to muscle failure. I terminate sets with 1, 2, or 3 repetitions left. And so my shoulder wasn't used to it. So about someone has their, hold on one second, I got to mute. There we go. Okay, so in any case, it was for my shoulder, more specifically my left shoulder, reacted to this, and it was too high of an intensity, too high of a volume. And about 2 days later, I started having aching and throbbing in my left shoulder. The aching and throbbing actually lasted for more than a month, probably 4, 5, maybe even 6 weeks. But the thing is, it was very intermittent, so it wasn't a constant thing. I also had a little bit of numbness and tingling going down to my elbow on occasion, or even my fingers, but it was really intermittent, and it was very dependent on what I was doing during the course of the day. So because it was so intermittent and it wasn't really painful, it was just this throb that was going on, I chose not to see, a physiatrist or physical therapist, especially since this is what I do for a living. So I was being stubborn, and next thing you know, after about 5 or 6 weeks, everything went back to normal. No more pain, no more numbness or tingling. I went back to, lifting the regular weights that I lift. And I actually was even progressing back to pre-pandemic strength levels. So everything was good. And it was good for about another 6 weeks or so. And then maybe even more than that, maybe even like 2 or 3 months, my shoulder felt fine. And then for some stupid reason, I decided to go really heavy in a bench press, which obviously in hindsight, I should have never done. Because I'm in my 50s now. So I usually just, that stuff that from my 20s and 30s, I don't know why I did it, but next thing you know, it flared my left shoulder up again. And I didn't feel numbness or tingling, but I started to feel that throb and that ache. And once again, it was very intermittent. It wasn't so painful that I felt like I needed to see a rehab specialist about it. But I decided what to do. I decided what I was going to do was I was just going to take like 3 weeks off and not train my upper body at all. So at about the second week of not training my upper body, and this now goes back to about 2.5 months ago. This was on April the 3rd, Saturday, April the 3rd. I was now in my second week of where I just completely left my upper body alone, didn't train it at all. And as crazy as it sounds, I was in the gym on a leg press machine. And I was, doing the leg press, but I was gripping the handles at the side to stabilize myself. And since this is what I do for a living, I know not to grip too hard. I was gripping just hard enough to help stabilize myself with the load that I was using. First set felt completely fine. I increased the load. Second set, I'd say about 3 repetitions into the set, I felt pop, pop in my left shoulder. There was no pain, but I felt some popping sensations. And my right shoulder, I have dislocated this twice, and I've partially dislocated it about 4 times. So I know what it feels like to have a dislocated shoulder. I also know what it feels like to have biceps tendonitis, because I've suffered from that before. And this felt completely different. It was not painful. It was just popping sensations. And similar to some people who feel like maybe they need to crack their knuckles or something like that, I just felt like my shoulder needed like to be cracked or something. It just felt off. So in any case, I didn't stop my set. Because there was no pain associated with it, I did another repetition of leg press. Everything felt fine. The next one was prescribed to be my last repetition. I did that. Pop, pop. I feel 2 more pops. And I know in hindsight that what happened was I hadn't ruptured my long head of my biceps yet. I had torn it. And the reason why I know that is because I terminated the set. I stood up, and the first thing I did, once again, there was no pain at all. I just started to like lift my arm to see how much range of motion I had. And, we're supposed to have 180 degrees of flexion and abduction. I only had about 10 degrees, 10, 15 degrees. And then my shoulder was basically just saying, you better not move me anymore. So I knew right then that whatever I did, even though there wasn't any pain, I did some serious damage to my shoulder. So in any case, I discontinued the workout. I walked into the locker room. It happened to be cold that day, so I had a sweatshirt that I needed to put on. And I was wondering how I was going to get my arm in the sweatshirt, but fortunately I was able to do it. I stood in front of the mirror to look to see what my range of motion was. And once again, it was only about maybe 15 degrees of flexion and abduction. So in any case, over the course of the next 4 days, I had some minor, I still just wasn't in pain. I had some minor ache, some discomfort, but no pain. And sorry, I was admitting some people to the room. And my range of motion was actually increasing a little bit. It had gotten up to maybe like 60 degrees of flexion and abduction. So I was thinking to myself, oh, things are healing, and I'm maybe I'll be okay in a few weeks. On day 5, which was April the 8th, I was in the shower and I was reaching towards my head to, I don't know, wash my head or something. And I felt 2 more pops. And even though once again, there was no pain associated, I knew right then that whatever I did, it was really bad. So I finished my shower. I look in front of the mirror and I can see that I don't know if you probably can't tell. Yeah, there we go. This Popeye bicep. It's supposed to be attached up in here. And for the first time ever, I saw the Popeye look, and I knew right then I had ruptured my bicep. So in any case, the very next day, I saw a physiatrist and an orthopedic surgeon who interestingly told me at the time they thought it was only a ruptured bicep. I got x-rays and an ultrasound, but not an MRI. And they told me that I probably don't need surgery. So I learned right then that strength and power comes from the short head of your bicep and not the long head. And that the long head is the primary function is really just shoulder stability. And that from an aesthetic standpoint, they said you can have surgery if you want, but it's really just to fix that Popeye. It's not, you really are going to be able to go back to your normal strength, or very close to it, even if you don't get the surgically repaired. Several days later, I had an MRI, and the MRI showed that I had a 1.3 centimeter tear of my supraspinatus tendon, which is known as a large but not massive tear, but it is a large tear. But it also showed some retraction of the tendon. And it showed that I had a partial labral tear, superior labrum. So there was definitely a lot of damage going on. And I ended up speaking to 2 more orthopedic surgeons, 2 more physiatrists, and about 4 physical therapists. And one of the orthopedic surgeons recommended surgery mainly because of the retraction. And he said that you're really at risk for progression of the tear. And if that happens, your shoulder over the time is going to start migrating superiorly, and then you risk bone on bone and eventually a shoulder replacement surgery down the road. But the other 2 orthopedic surgeons I saw did not say that. They said you have a good foundation of strength. Your MRI shows that your other 3 rotator cuff tendons are intact and they look strong. And as long as you're smart about not doing overhead lifting or explosive things, you'll actually probably be okay. So, and they also said that I didn't need, if I did opt for surgery, it didn't need to be right away, that this could be a decision that I could make down the road if I want. So since this is what I do for a living, I'm 55, I'm getting ready to turn 56. And from an ego standpoint, I kind of wanted to just show the world that that someone in my age group can get back to at or near pre-injury strength levels. Because as you probably know, there is a ton of research on rehabilitation for this type of injury in a rehab setting. And there is a ton of research for rehabilitation with this type of injury for athletes and a return to sport. But there's almost no research on this type of injury for someone like me, who is in shape, middle-aged, wants to get back to the gym. And I basically wanted to be in my own case study and show the world that you can rehab back to, despite the large supraspinatus tear with retraction, that if you're smart about it, you can rehab yourself back to at or near pre-injury strength levels. So I'm going to end this presentation with this video, and then we can open it up to questions. And this video relates very closely, obviously, to everything I just said, because all I'm doing The only thing I did for myself was I determined my initial capacity in week 1. I didn't start my rehab until about 3 weeks after the initial injury. So I'm really only about 6 weeks into my rehab right now. So keep that in mind. I am only 6 weeks into rehab with a significant shoulder injury. And all I did was I started with my initial capacity, and I was really conservative. You're getting ready to see very conservative with my loading. And I didn't even come close to taking myself to muscle failure. These were really light warm-up weights. I was a little scared, and I just wanted to see what would happen with any type of a load. But over the course of time, you're getting ready to see in this video, my confidence started to increase, the load started to increase, and taking myself closer and closer to muscle failure is what happened. So here we go. This video is a quick update on my shoulder rehab from a ruptured biceps tendon and a large tear of my supraspinatus tendon. Currently 9 weeks out from this two-phase injury, where the biceps rupture and the rotator cuff tear happened on April the 8th, and I'm way ahead of where I thought I'd be when the injury first happened. I started my rehab on May 5th, about a month after the injury. I was only chest pressing 30-pound dumbbells for 2 sets, rowing about 60 pounds for 2 sets, and trying to figure out what shoulder exercises I could safely perform. The back row exercises felt fine, and although I did feel some discomfort when performing chest presses and shoulder exercises, it was minimal. But I purposely went very light on everything, because even though it felt fine while I was doing it, I was a little apprehensive about how I'd feel over the next couple days. By May 23rd, my chest press was up to 40 pounds. Back rows were up to 110 pounds. And I increased my volume to 3 sets of each instead of just 2. I felt like I had found safe and productive upper back and shoulder exercises with face pulls, cable lateral raise, which includes some shoulder external rotation, cable 90-90 for my rotator cuff, some biceps curls and triceps pushdowns exercises. At this point, I was noticing it really felt like my shoulder was starting to heal, because I'd feel less and less discomfort during the workout, and during activities of daily living, I'd also feel less discomfort. By May 31st, I was chest pressing 50-pound dumbbells, and rowing 130 pounds, both for 10 reps. And I also increased my volume to 4 sets of each. Stuck with my same shoulder exercises because if it ain't broke, don't fix it. These exercises are working, and I prefer not to change anything right now. Last weekend, I traveled to Knoxville to present at a physiatry conference, and I wasn't able to get in and work out because of it. But yesterday, during my leg workout, I decided to try deadlifting for the first time. After a quick 2-rep warm-up with 135 pounds, which felt like nothing, I put 225 pounds on the bar and got 8 reps. It felt like a moderate warm-up, and my shoulder felt perfectly normal and stable. Today, I continued to progress, chest pressing 55 and then 65-pound dumbbells for 10 reps. Didn't have 60-pound dumbbells, which is why I made the big jump, but everything continues to feel pain-free and stable. The slight discomfort I had in the front of my shoulder during the first few weeks during chest presses is now completely gone. Threw in barbell rows for variety, 145 pounds for 10 reps. I continue to stick with a volume of 4 sets for my chest and back exercises. I also continue to stick with my standard shoulder exercises, and I doubt I'll add in anything different for at least another month or so. My bicep curls are up to 30 pounds for 10 reps, and I don't feel any of the fatigue or cramping that I've been told would happen. I've been doing a second workout each week during the week, could stick with 2 to 3 sets of everything at about 75% of the weight that you see in these videos. So I purposely haven't been recording them. So overall, I've been progressing at a much faster rate than I thought would be possible when this injury first happened. I really don't feel like I've lost much strength at all. I think I'll be back up to at or near pre-injury strength levels by the end of the summer. The only thing that sucks is what my biceps looks like now, since it's obviously dropped. I now have that stupid Popeye look. Being back in the gym and progressing quickly is by far what's most important for me. Also extremely glad I didn't opt. All right, so I'm going to end it there and just say that this was from 2 weeks ago. I'm now up to 70-pound dumbbells and 150, 160-pound rows. I'm sticking with the same shoulder exercises. You know, and I obviously had started with a good foundation of strength. So I'm an outlier in that sense. But I just want to say that, and I'll end with this, that since I never had any swelling or inflammation, not even from the very beginning of the injury. So that part was out of the equation. And then as soon as my bicep ruptured, so when it was just a tear for those first 4 days, I was very limited in my range of motion. But as soon as it ruptured, within the next 24 hours, I had full range of motion because there was nothing attached anymore. I had discomfort in abduction since it's a supraspinatus tear. But otherwise, I just didn't have any discomfort and I had my range of motion. So the point is that phase 1 and phase 2 of rehab, where it's negate pain and swelling and restore to at or near full range of motion, I pretty much didn't go through that. So all that's really left is motor control and strengthening. And those are the phases that I've been in really since workout 1. And so my mind frame for myself would be the exact same thing for when patients are referred to me. By the time patients get referred to me, their pain and their swelling is either gone or very minimal, and their range of motion is either has been restored to normal in physical therapy, or it's near normal. And so at that point, I just want to, if it's not quite normal yet, I just want to put them on a flexibility program to restore it back to normal. But in the meantime, at that point, it's really just about motor control and strengthening. And my job, and I believe the job of a physiotherapist, is to determine the person's initial capacity, a nice, safe box to place them in, and be conservative, be very conservative. And then use your education, use your experience, use your skill level to, and those RPE scales to start to progress them in intensity over the course of time. And since it's my body and I know what I was capable of, it obviously makes it a lot easier to progress myself. It's not so easy when it's not your body. But the truth is, ultimately, my goal was to load to the point where the velocity of movement started to slow. And that just happened last weekend with those 70-pound dumbbells. So I've lost a little bit of strength, but I'm probably at about 85% of the strength that I had prior to the injury. And to me, it's the concepts are simple. It gets complex when you have to start talking about exercise selection and rates of progression and things like that. It can be a little complex, but the concepts themselves are simple. If the range of motion is there and the tissue is healed, muscle tissue that is, and the pain and the swelling are minimal, we got 2 things left: motor control, strengthening. Let's start to progress them. So, we can open up to question and comments, and Andrew and Sam emailed me, or Andrew emailed me some pictures of hold on, I have to admit some people, I think. Oh no, we're good. Emailed me some pictures of the equipment you have access to, and I was just wondering if you wanted to briefly talk about that, because it makes it difficult, to move someone across the strengthening continuum and move someone across the repetition range continuum when you have access to not a whole lot of equipment. Like, for instance, from a lower body standpoint, we have bilateral exercises and unilateral exercises, and fortunately your patients have access to a leg press.
Yeah.
I don't know how much.
Andrew sir, would you like to take it? Yeah, we are the area of our work is primarily in the early phase of rehabilitation.
Okay,
We kind of more of a adaptive phase, but we also have certain the avenues to follow the patient up, progress them over weeks and months.
good,
If not for everybody, for at least for a certain percentage of our patient population, there is
good,
scope to do that. And you rightly brought out the continuum, right from the adaptive phase to progression. That's exactly what we wanted our people to kind of think about
good.
when we are dealing with strengthening, and not to only stop at the initial phase. But being primarily a tertiary medical care facility with a very limited follow-up options, uh, a major portion of them come to us for a very short period. So one of the questions in the chat is about that, where we kind of deal with patients or persons who come to us only for one session, two sessions, or three sessions, and after that, we may or may not have the follow-up at least for another 6 months to 1 year. So what exactly should we tell them or guide them for those population?
Yeah, I'm trying to find the question in. Is it the question where it says in a setup where you have only one session with a patient?
Yes,
What
yes,
is the best
exactly.
way? Yeah, I mean, so look, it's a difficult question to answer because we can only work with the means that we have. And that's the reason why I included that slide on motivation and means, and the fact that there's a low end of the continuum and a high end of the continuum. We can only work with what we have. And so if you only have one session, in a perfect world, and look, there's so many variables. It depends on so much on the injury, where they're at in their rehab process and their healing process. So there's so many variables that I would need to know more about to answer this question. But generally speaking, you want to use your biggest bang for your buck exercises. And so that's going to be things like loaded sit to stands or loaded squats, loaded hip hinges like deadlifts and hip thrusts or bridges for your lower body. And then for your upper body, it's going to be your pulling and pressing exercises, whether it's a chest press, maybe shoulder press. Obviously, it depends on what's going on with the shoulder. We might have to stick with more rehab type shoulder exercises like you see me doing in that video. But the point is that the way when you're really limited and it's only one session in a scope of a week, try to pick the biggest bang for your buck exercises that you can and try to get as high of a volume as you can. Maybe it's not just 2 exercises per muscle group, but it's 3 or 4 or 5. If progress them at some point to 5, because the higher the volume and the bigger bang for your buck exercises, the more optimal the program is going to be. It's a really tough situation when you only have once a week. It's going to be tough to get that person to move forward in the continuum of strength, tissue healing, tissue strength, etc. Just got to do the best you can.
Yeah. Let me pick another question in random here. What about stretches before strengthening? What's the physiology and the professional perspective on that? Is it always recommended to stretch before strengthening?
Yes.
Or is it otherwise wrong?
Yeah, so that's kind of an it depends situation. Generally speaking, the answer is no. You want to do dynamic stretching. So first we have to differentiate between types of stretching. There's active or passive stretching in one category where the goal is to increase range of motion, where you're going to hold the stretch for 20 seconds, 30 seconds, a minute, 2 minutes, where the duration of the stretch is longer. And then there's dynamic stretching, which by definition is anywhere from a moment in time, like a leg swing, up to about 3 seconds. So we have to differentiate between the type of stretching. Dynamic stretching is great before a resistance training, session, because you're activating muscle tissue, you're starting to activate your central nervous system, you're getting muscles warmed up and joints lubricated and things like that. So Dynamic stretching is great, but holding a stretch for 30 seconds, 45, 60 seconds or longer, the answer to that is, first of all, you probably shouldn't do it. You probably should avoid it. But the truth is, you actually could do it if it's 30 minutes prior to a session and you're only doing like one set for like 30 seconds. So the point is, if the volume is low, if the duration is low, and if you're doing that stretching 30 minutes or longer prior to the session, it probably isn't going to have a big effect on a session. But having said all that, I personally wouldn't do holding a stretch for any real length of time. Just do your dynamic stretching to activate things, do some sort of graded warm-up exercise routine, and then get into your lifting exercises.
Thanks, Jeff. Just one more question on dealing with persons with neurological dysfunction, like 3/5, 4/5 muscle power, and then parallelly working with healthy individuals. What physiological difference does it make between these two groups when it comes to strengthening, when it comes to recruitment of motor unit, motor fibers?
Yeah, so I got your whole question except for the second group that you were referring to. What did you say? Older population?
The healthy ones, the healthy adults.
Healthy. So those with neurological issues and those who are healthy?
Yeah, exactly. Yeah.
No difference. So my wife has multiple sclerosis. So there's no difference in the loading and the repetition ranges as far as what it will do for the nervous system. There are major differences in your start points with that individual and your rate of progression. And so I'm going to use my wife as an example. She was diagnosed with multiple sclerosis 17 years ago. Her health was spiraling downhill for the first 5.5 years, daily flare-ups. It was really bad. I also didn't know what I was doing compared to what I know now. So I also didn't know how to put her on a proper program. But long story short, what we did initially, some of it was just kind of some fear from my end because I didn't want to load her up too heavy and push her too hard. So I kind of kept her in that 10 to 15 repetition range. And there's no way we took sets to muscle failure. Well, we definitely terminated sets knowing that she could have performed 3, 4, or 5 more repetitions. So the RPE was probably only about a 5, 6, or at the most a 7 on a scale of 1 to 10. And I kept her at that range, honestly, for probably a couple years. But her health was then improving. She was getting stronger. Her diet was better. You could just see that her flare-ups weren't as frequent. They weren't as severe. So she was feeling better. And so at some point, I decided, probably about 2 years into it, I decided to shift things from 10 to 15 repetition range to the 8 to 15 repetition range. So on occasion, we started loading up at 8 repetitions, just occasionally, like maybe once every 2 months or something like that, just to see how her body would respond. And sure enough, she's eating healthy. So there's other things involved with it. She's eating healthy, she's sleeping better. Her disease progression is starting to slow. The associated symptoms are slowing, and she's responding well to these heavier loads and lower repetitions. So I started to make it more common in her program so that like once a month, she'd spend, maybe not once a month, but she'd spend longer phases at 8 repetitions per set as compared with previously. Her body responded well. So we stayed there for a couple of years. And then I started to introduce 6 repetitions per set. And did the exact same thing. It might have, for the first year, it might have only been like 3 or 4 times in the scope of a whole year that we would do as low as 6 repetitions and increase the weight accordingly. But sure enough, so physiology applies no matter what your age range, no matter what the condition. The physiology is the same. Your heavier loads are going to activate more motor units, no matter what your age or condition, and lighter loads are going to activate less motor units. But you just have to be smart about the progression, about where you start them, the rate of the progression. Just kind of insert things on occasion and see how their body responds and adapts. And if it's responding and adapting well, start making it a regular part of the program. That's what we did for her. And you see, Sam, that she's now deadlifting and squatting like weights that a lot of men can't do. It's crazy, this type of stuff she's doing. So yeah, hopefully I answered your question, but really the only difference is start points, rate of progression, the exercises you select, someone might not be able to do squats because of balance issues or something like that. So exercise selection plays a role as well. But from a physiological standpoint, there really isn't much difference.
Thank you. We're hitting time here, but we'll take one or two questions more on this. One question is the big decision that a physio takes when he sees the patient for the first time is to decide on that initial resistance, initial weight. So how do they go about deciding on the first weight that they put on the patient,
Yeah.
and then the rate of progression?
Yeah.
We did see from your slides about a few weeks periodically. But what's your take on the initial weight that we need to decide upon?
Yeah. So this is probably the most common question I get actually from my clients. For instance, for clients who can only afford 5 sessions with me, and then they're going off on their own, and we haven't really had a chance to progress them at all. And they'll ask me this question: how do I know when I go to the gym, what weight do I use? And my answer to the question is always the exact same as what I presented in this presentation. You have to go to that RPE scale. So in the beginning, it's obviously a guessing game. All you can do is guess. You have to kind of, you have a sense of the person's fitness level. And, so many people are deconditioned. And my view is whatever you think is erring on the side of caution, you err even more on the side of caution. So so that might mean just 2-pound weights or 5-pound weights or body weight, depending on the exercise. So you just have to get used to what it means from an experience standpoint of erring on the side of caution. For the lower body, probably just body weight. For the upper body, probably just very light weights. And then you use those RPE scales. So Sam, if you're my client and this question applies to you, and you want to know, maybe you're my patient, and and I'm trying to figure out what loads I'm going to use for you for every exercise. I'm going to start conservatively, very conservatively, and at the end of every single set, no matter what the exercise is, I'm going to ask you on a scale of 1 to 10, how did the last repetition feel? And you're going to have to give me some sort of answer. And hopefully, if I did my job right, you're only going to answer like a 2. And I'm going to know that I loaded up too light. It's too light. So on the next set, I'm going to increase the load a little bit in the hopes that at the end of the set, you answered the same question that felt like about a 3 or a 4. And my goal in the beginning is to try to choose loads where your answer to that question is about a 4 or 5, where it's still a warm up. I didn't see the velocity of movement slow. I didn't see any look of strain on your face, but I can tell that you were at least doing something, and it wasn't, like nothing. So you have to use the rated perceived exertion scales, look of strain on their face. You want the velocity of movement to not slow. You want each repetition to look the same, but you want to ask them how it felt on a scale of 1 to 10. If you see the velocity of movement slowing and a look of strain on their face in the beginning, you loaded up too much, and you got to decrease the load on the next set. So the goal initially is to find loads that are about a 4 or a 5 on a scale of 1 to 10, where it's still a warm-up set, where the velocity movement didn't slow, it still looked the same, but where you can tell that they were at least having to put a little bit of effort into the set. Does that all make sense?
Right, that's correct. Use RPE or VAS to determine their levels, and then move on from there.